So I figured I would talk about something a little different than specifically spine today. And this is a compendium of the work that we've working on for the past year or so as a research team. We're going to talk about red blood cell transfusion guidelines in neurosurgery, or at least the best evidence that we have so far. Why this matter or is important? Because transfusion are given profusely every year. It's a very rare and expensive commodity, and everyone here has argued with the blood bank over hemoglobin thresholds for a reason. One, there's risk with transfusion, risks that are infectious, much less now than before, and also transfusion volume-related reactions such as TACO or TRALI. And there's also the issue of RVC storage, where if we try to store the red blood cells more than 30 days, they're arguably storable until 42 days. The quality of the blood becomes worse. So the oxygen carrying capacity becomes inferior. It's loaded with free radicals. So in the setting of trauma or patients that are septic or SIRSI, that could be arguably not a good thing to do. And the blood cells themselves become embolic after a long time. So the trial that started this whole discussion, or one of the main trials that started it, is the Transfusion Requirement in Critical Care, or TRIC trial, back in 1999, and it's still being referenced today, where about 6,500 patients were assessed for randomization initially between a liberal strategy of less than 7 or 8, or more, of more than 9 or 10, or restrictive strategy of less than 7 and 8. But they ended up only with 838 patients that were consented for that randomization because a large volume didn't qualify, or even the patient or the physician refused. Of note, in these patients, only 13% of the initial cohort that was considered ended up being randomized, and only 71 of these patients were neurosurgery patients with a TBI or subarachnoid hemorrhage. And the conclusion of the trial was then a restrictive strategy is the same or better than a more liberal strategy, and that's what started this whole discussion. But what's the quality of this evidence that is still being referenced to today? This is a paper from the American Association of Blood Banks that looked at basically the guidelines that we have currently, just to look at the quality of the evidence. And they reiterated that hemoglobin of less than 7 should be a trigger for transfusion, including ICU patients, unless they had a cardiac history or undergoing orthopedic procedure with pre-existing conditions. Then you can use 8. And they said that they stuck to that threshold because there's no solid evidence in any subcategory of the TRIC trial, and there was no mention of neurosurgical patient again, and all evidence was of moderate quality according to these guidelines. A group in Belgium looked at the quality of evidence specifically, and they basically went through all the recommendations one by one through a very detailed algorithm that rated from 0% to 100%. It was 4 independent assessors. They reviewed all the current trial for the quality and the methodology of the recommendations, and they assessed the 13 transfusion guideline of the ABC, and they found that the quality varied between 18 to 70%, so it's very variable, and only 4 of the recommendations had a high quality of evidence. So what we decided to do, in part to see what the evidence was for neurosurgery, in part because we were aggravated of discussing threshold with the blood bank all the time, we looked at basically the evidence in each one of the neurosurgical, or most of the neurosurgical subspecialties, and we're actually looking for partners to do that in peds, which is a little more tricky because it's also multiple subspecialty in pediatrics, but the numbers are very small. So we looked at it for spine, for vascular in the setting of subarachnoid hemorrhage, for cranial tumor surgery, and for traumatic brain injury. These are the levels of evidence that we use. It's the AHA classification, where you go from A, B, C on the vertical axis, depending on the number of patients basically that you have. And then you go through classes 1 through 3, where class 1, you absolutely should do something. Class 3, you should not do it because it harms or does not benefit. And class 2, you could consider or it's reasonable to do. So the recommendation to do something usually is a class 1 or a class 2, and the class 3 is do not do something. The first one was on spine. It was published in the Spine Journal fairly recently. And we went through about 1,169 references manually with 3 different assessors. And we basically removed the meta-analysis based on the PRISMA guidelines, removed the systematic reviews, and just looked at the raw data. We ended up with 22 studies that talked about evidence for a threshold of hemoglobin transfusion. We did not look at pure complications from transfusions or triggers that should be used for a transfusion in the setting of spine, because these were very variable. We just looked specifically at a threshold of hemoglobin and how that impacted outcome. So the conclusions were surprising. The overall conclusion of the evidence we had is that transfusion is or cannot be recommended in elective spine surgery. So level B of strength, which is decent, and a class 3, because it caused harm overall. So we found that spine patient that overall got a transfusion had increased postoperative infection, increased superficial and deep wound infection, more chance for sepsis, pulmonary urinary complications, cardiovascular complications, and were more likely to go back to the OR with an increased length of stay and increased readmission. This being said, the population in spine that requires a transfusion has an increased propensity for these complications regardless of a transfusion. So there may be some confounding factors that could not be teased out outside of a randomized controlled trial, which is also difficult to do. Also notable to notice that the triggers for transfusion for spine is not always a hemoglobin threshold. It's also instability in the OR or predicted blood loss, meaning after a Scoli case, if you lose about 500 to 600, halfway down, they're going to need volume. That's when we transfuse blood. In the setting where a transfusion has been triggered or a recommendation transfusion has been triggered, it is better to transfuse high, meaning if you are going to transfuse these patients, 7 is not what you need to go by. You need to follow 9 or more intraoperatively or 8 or more postoperatively, because this has been shown to have better outcomes as far as functional status and fewer wound infection, and that's a strength level B. So overall, try not to transfuse, but if you do transfuse, 9 or 8 is what you should follow as far as what's available out there. We looked at transfusion in the setting of subarachnoid hemorrhage, and that's been published in World Neurosurgery. Very similar approach where we looked at about 313 references. There was less articles or fewer articles published when it came to that hemoglobin threshold in that setting. And this is something I've actually presented maybe 4 years ago as a vascular conference, but there were more studies added since. We ended up with 16 studies in the final analysis after we excluded a lot of the papers that were published. And then we found that in general, and that's something we knew already, patients who are more likely to receive a transfusion had a worse bleed, so WFNS score of 4 or 5, Fisher 3 or 4, or had comorbidities that were heavy, such as diabetes, hypertension, or cardiopulmonary diseases. And then transfusion were associated with more complications, same as with the spine cohort, with a high rate of vasospasm, surgical site infection, length of stay, and 30-day mortality. We still have the same confounders, since this is the population that at baseline has a worse bleed and has more comorbidities since a transfusion has been triggered. The difference is that in transfused patient, hemoglobin goal of more than 10 was recommended if you're going to go ahead and trigger, just because it was shown to improve clinical outcome and reduce cerebral vasospasm, and it's a decent level of B with a class 2A. So, strongly consider with a cohort that's just short of meta-analyses as far as what's available. And that probably has to do with the oxygen carrying capacity of the blood at 10. For cranial surgery, this is currently under review. We did a similar approach, and the data is even less than it was for subarachnoid hemorrhage, where we ended up with only 7 studies in the final analysis out of 571 that were screened that actually had good quality data or qualify for meta-analysis based on PRISMA. And similar trend, patients who received transfusion at baseline had multiple major and minor complications after surgery, longer lengths of stay, increased return to the OR, and 30-day mortality. And the transfusion threshold are actually very restrictive in that category, where it's level C class 2A recommendation to withhold RBC transfusion, and to keep it restrictive to less than 8, as it reduced length of stay mortality complications. So the main difference between this and subarachnoid hemorrhage and spine is that for all three, it's bad to transfuse, but for a tumor, brain tumor specifically, if you are going to transfuse, you want to be as restrictive as possible. Probably has something to do with the fact that subarachnoid patient need the oxygen carrying capacity of blood, so higher threshold. Spine patient need to be able to ambulate despite the big wound. Probably that's why you need a higher hemoglobin threshold, but that remains to be proven. And finally, we looked at traumatic brain injury. We started with 472 references and ended up with 15 studies included in the final analysis. And you know, same trend, transfusion are associated with a higher mortality, poor 90-day outcome. It was a class B level 3 to recommend transfusion in TBI patients, meaning you would cause harm. And if a transfusion is needed, you want to be extremely restrictive because the outcome was significantly worse if you went up to 9 or 10. This is actually one of the few categories that showed harm with transfusion, probably because traumatic brain injury is a prothrombotic state. So if you add transfusion, add that prothrombotic factor to it, you're going to worsen outcome on top of the initial trauma. So this is something important. And the trauma physician know that very well. People tend to do much worse if you transfuse them liberally in the setting of trauma, especially traumatic brain injury. Went through it a little fast, but I'm happy to take some questions. It's just pretty much the quality of evidence we have now for transfusion in neurosurgery.
Interesting body of work.
Yeah, I was just tired of the blood bank arguing with me, to be honest with you, and I figured I'd see what's what instead of referencing to something that doesn't apply.
But you've ended up proving that, right, a lot of times?
A lot of times they're right, sometimes they're not. Like in the settings of arachnoid hemorrhage, you definitely can ask for a higher hemoglobin threshold if you need it. It's better not to need it, but if you do, you can ask for a higher one, and they shouldn't argue. For spine, also you shouldn't transfuse, but a lot of our deformity cohort are going to need a transfusion. It's a fact. Like the Scully cases need between 4 to 8 RBC packs, and that's the reason why we try to keep them above 8 or 9, because, you know, anecdotally we saw that they do better, they can walk better. If instead of dropping them from 15 before surgery to 7, we drop them from 15 to 9,
right.
And there's a reason for it. It's just it's not 12, and it's good to have the numbers to kind of go with that.
Did you map? Again, I came in right as you were getting to the data part. Did you match them for a preoperative how they work? Because when you
No.
get associated with high postoperative outcome, you know, worse postoperative outcome.
No, and these are the confounding factors we can't account for. These are confounding factors we can't account for. We can't match them for that. And when you're doing the meta-analysis there, because we don't have the raw data from all the series, a lot of them didn't even collect it. So in a lot of these studies that were basically not included, they didn't even grant importance to preoperative factor. It's more of a surgical technique they're describing or something like that. That's why we need a good randomized controlled trial that'll account for all that. And it has to be multi-institutional.
And so I have 2 questions. I think I don't know the literature about spine that well, but last time I looked at it for all kinds of cranial indications. Out of all these, there were only 2 randomized clinical trials. So out of your literature review, how many of them are actually randomized clinical trials?
None, because to do the meta-analysis based on the current PRISMA guidelines, we cannot include any kind of trial that hasn't basically speciated, meaning if it's only 2 randomized control trial, actually they should be included. No, you're right. These should be included.
You can.
Yeah. The randomized trial will include. The meta-analysis were not. So these trials should be included in there. I can send you the raw data too. Yeah, but the randomized trial should be included. So if it's a class B, that's because of the trials. Because otherwise they would be C.
The point I wanted to make is that the number of randomized clinical trials are really minuscule. Most of them are, we took a bunch of patients, you know, And then at the end of 3 months, we looked at the ones that did well, and the ones that did well had
100%.
hemoglobins of 10, and the ones that didn't do well had hemoglobins of 7.
Yep.
Therefore, A is better than B, which is
100%.
probably doesn't exclude a whole lot of factors.
Most of the studies are actually, like you said, retrospective analysis. So most of them are level C. Very few randomized control trial level A. And the way we did that, if most of the levels were B and C's and just one A, we're not going to give an A recommendations.
The other question I had was, did you look at, or are there any plans to look at platelet transfusions? Because that is, again, a huge area.
We haven't, but it definitely matters, because when we give blood for spine, we have to give a matched transfusion. So we give them platelets and FFPs as well. So we can look at that independently or dependently with RBCs, but that could be its own separate study. We can do that for all the tenets as well.
Sorry, I've never heard of that concept before, matched transfusions.
Oh, so whenever we give them RBCs, we can't just give them red blood cells. So
We can't.
well, we can,
Yeah.
but they're not going to do well. So we have to give them.
So just as an outsider, I've never heard that before. So when you say it as like the law, it's an interesting.
Sure. So it's like in the massive transfusion protocol they have in trauma. When we start having a bloodless about 1 liter or more, so it applies more for scoliosis cases because we know they're going to lose that much. If we give them only packed red blood cells, it's going to dilute their coagulatory factors. It's going to dilute their platelets. So we have to account for that dilution effect, because they're losing that as well. So we have to give them, depending on a certain ratio, red blood cells and platelets and some sort of factors. So for us, whenever it hits about 3 RBCs, they give a unit of platelet, and we have that protocol too. And then if we have to give more than 3, they have to get the FFP as well. And we can see it in the field, like the blood just is very runny. It's not really coagulating anywhere.
So a couple comments. One is you said reasons not to transfuse. Might have implied it, but there's a huge literature on the immune suppressive effects of transfusion.
Absolutely.
So I think that's important for everyone to explicitly, I think the other thing is, we tend to, at least when I was in training and away from it, if you transfuse, you give 2 units, right? And then there's been a move away from, you don't have to give 2 units every time you give someone blood. The last thing is, especially on the TBI side, we've seen it that physiologically driven transfusion rather than threshold driven transfusion based on blood tissue oxygenation or other physiological factors, which is probably why these numbers thresholds are tough, because patients' physiology just differs. There's so many other factors. So ultimately, I think that's what we need to think about is physiology, not just the number.
No, absolutely. A lot of the new sensors now will give you some sort of cortical oxygenation number. I'm not aware of any study that's driven transfusion based on that yet, but that'd be interesting.
There are LICOC studies that include transfusion as part of the management protocol.
Okay.
Blood tissue oxygenation. That's
Yeah,
they've been around for over a decade.
Okay.
Because I know the protocols were there when I was a resident, but they were still being investigated. So.
Yeah, even before LICOX, there were thresholds based on jugular venous oxygen content numbers also. Again, these are not randomized controlled trials.
Exactly.
Probably one step ahead of just picking a number and saying everybody has to be at 8 or everybody has to be at 9.
Salah, can you talk about your control model in the spine transfusion? Like what exactly went into the model and how you controlled for the patient variability, for the underlying differences in who needs one?
So this was just a Prisma-driven meta-analysis. We did not account for variables and I'll show you again. So we could not account for basically admission hemoglobin, functional status at baseline for the patient, operative time, technique used, the implant used, but that is currently in the works. That kind of granularity is hard to do unless you have the raw data from all the studies. And I can send you the big spreadsheet we have from all the, the 22 studies we included there, but it was hard to account for the patient factors going into it. All we had was a retrospective analysis of what they did after surgery, or how they did after surgery. The level of evidence, a lot of time, was driven by the quality of the study itself. Meaning, how good was that randomized control trial that they did? Not that there were any randomized control trials for spine, or how much of a quality that retrospective study gave us.
All right, thanks, Salah.
Thank you.